What do the following sports have in common?
Jump around, jump around, jump around.
Also known as jumper's knee, patellar tendinopathy is an insertional tendinopathy that most commonly affects the patellar tendon origin on the inferior pole of the patella. It is not an inflammatory condition, therefore the term tendonitis is not accurate. Instead, it is a degenerative tendinosis. Our learning objectives are as follows. Describe the conservative treatment for patellar tendinopathy and the possible mechanisms. Describe the surgical treatment and its procedure. And identify when the use of each treatment is appropriate.
My name is Damian Sevilla. I play on the varsity volleyball team and I have patellar tendinopathy. During activity, I had sharp pain right underneath my patella. Started off during the season and it was mild at first. It hurt when I played a bit, went away when I was warmed up, and then it progressed to the point where it hurt when I was playing, when I was off the court doing basic stuff like walking. Once our season ended, it took probably a month off, and then
Given Damian's symptoms, with the person beside you, discuss what treatment he should do. We will now discuss the eccentric training treatment option.
Eccentric training is when the muscle tendon unit is lengthened as a load is applied. One of the current conservative treatments used for patellar tendinopathy is a type of progressive eccentric training program. There is currently confidence among clinicians that the use of eccentric training programs for patellar tendinopathy will result in positive effects on pain and improved function. There are two common types of eccentric training. The first type utilizes a 25-degree decline board. Participants were instructed to experience moderate tendon pain and to increase the load if pain eased. The second type uses a 10 centimeter step. Unlike the decline board, minimal tendon pain was required, and there is a progressive increase of speed instead of load. The study by Jung et al. Found that both eccentric exercises have shown to be effective treatments for tendon pain and improving sport function in athletes. However, when looking at VISA scores over a long term, the decline board protocol has shown to produce a greater benefit and higher likelihood of improving VISA scores. The VISA scores quantify the function of symptomatic knees. Although reviews have criticized the quality of some trials looking at eccentric training, there is still a body of evidence to suggest that eccentric training is an effective conservative management option. In a review that systematically examines the effectiveness of eccentric training on tendinopathies, a list of possible mechanisms were provided. The first mechanism proposed is that during eccentric training, the patellar tendon is subject to greater forces and therefore a greater remodeling stimulus. This results in lengthening of the muscle tendon unit and thus less strain. The second mechanism proposed is that eccentric training may provide a mechanical stimulus to inactive tendon cells. The third mechanism proposed is that eccentric training reduces tendon pain perception as it changes the metabolism of undefined substances in the tendon. The fourth mechanism proposed is that eccentric training may result in increased tendon stiffness. The fifth mechanism proposed is that eccentric training may induce sarcomerogenesis and increase fascicle length. This states the importance of looking at the whole muscle tendon unit involved in the mechanical adaptations. The sixth mechanism proposed is that eccentric training may result in a net increase of collagen in the tendon exercised.
We will now discuss the surgical treatment option. The most commonly performed surgical treatment is an open patellar tenotomy. This technique has been favored in most studies. Under local anesthesia, a longitudinal incision is made to fully expose the tendon. Tendon tissue is excised with the use of a full-thickness wedge-shaped incision. All abnormal tissue is removed. A study by Reese et al. Looked at the results from various studies that investigated surgical treatment. The review showed favorable outcomes in 46 to 100% of the studies. However, most of these studies were done with poor methodology. Furthermore, a correlation was found between lower methodology and high success rate.
Based on the information provided about the types of treatment for patellar tendinopathy, devise a treatment program for the person with the condition. Consider including one or a combination of both treatments. Be specific. For example, if using eccentric training, include repetitions, sets, times per week, duration, etc. If using a combination, perhaps consider stating the timelines for each treatment method.
There is only one randomized controlled trial that compares eccentric training to surgical treatment for patellar tendinopathy. Because it is a randomized controlled trial, it is considered level 1 evidence. Participants were randomized into two groups, an eccentric training group and a surgical treatment group. There were 35 participants in the study and 40 tendons were assessed, as some people had patellar tendinopathy in both knees. The participants performed squats on a 25-degree decline board. They were instructed to do 3 sets of 15 repetitions twice a day. No warm-up was performed. The downward or eccentric component of the squat was done with the symptomatic leg, while the upward or concentric component was done with the asymptomatic leg. The participants' back posture was vertical. The participants trained for a minimum of 12 weeks and were encouraged to continue training after this period. Open tenotomy surgery was performed. For the first 6 weeks post-surgery, participants underwent a rehabilitation program that had them gradually increase the number of training sessions and repetitions performed. After 6 weeks of rehab, participants started performing eccentric squat training according to the same training program as the other treatment group. Participants were evaluated after 3, 6, and 12 months. At each evaluation, the patients underwent functional testing, which included testing of jumping and strength. They also completed the VISA questionnaire, which quantifies knee function in people with patellar tendinopathy. The VISA score has been shown to be a valid and reliable measure. There was a definite improvement in knee function in both groups after 12 months. However, there was no significant difference between the two groups after 12 months. Additionally, the improvement in knee function was not overly impressive. Although both groups saw general improvement in terms of pain and function, only 7 and 5 participants from the eccentric group and surgical group, respectively, were completely symptom-free. Both treatments produced significant improvements in terms of pain and function, but only roughly half of the participants returned to their sports within 1 year of their respective treatments, and even fewer had relief of all symptoms. As a final conclusion, Barr et al. Recommended that eccentric training should be utilized as a primary treatment option before surgery is considered. A number of studies, including Reese et al., Pani et al., and Kahn et al., have concluded that conservative treatment, specifically eccentric training, should be attempted for at least 3 to 6 months. If conservative methods fail, then surgery should be considered.
Once our season ended, I took probably a month off, and then I started focusing on eccentric squats, decline squats in the gym. Probably did it for 3 months during the summer. Progressed, started with 3 sets of 10 each leg, and by the end of the summer I was doing 3 sets of 20. I did eccentric decline squats for 3 months, and I'm now symptom-free and playing volleyball with no pain.
You simply